Thanks for doing this, Rob. It's good to be here with you. Do you want to just introduce yourself to people who don't know you?
Yeah, so I'm Robert Scully, and within ScotGEM I'm the Lead Generalist Clinical Mentor, GCM. I'm a GP clinically, and I have an extended role in emergency medicine. So I work in an emergency department every week as well.
Cool. And when did you join the ScotGEM programme?
Yeah, good question. I was probably one of the first in the door. I think I started my post on the 1st of November 2017.
Cool. So just before all the students arrived?
In preparation for you guys arriving in September 18, yeah.
Cool. And so what is it that attracted you to kind of joining ScotGEM? Like what was the thinking behind it?
Yeah, I had a sort of a real eureka moment with ScotGEM because I was at a bit of I wasn't quite sure which way I was going to go with my career. I was looking at a few options at the time, and I started to read about ScotGEM, and I found the whole thing really compelling. There's obviously a recruitment crisis in general practice in Scotland, and a recruitment crisis in rural areas and for more generalist careers. Clinically, I'm really excited by generalism, and I felt that ScotGEM was a real root and branch approach to answering this problem.
Yeah.
So I was just as soon as I read around the program, I felt that this was a project I wanted to be involved with, and it was actually an old boss of mine that alerted me about it in the first place, and I felt I'd look into it a bit more. So I drove up to Perth and met with John Dowell for an informal chat, and after that I was absolutely clear that I wanted to work in the program. So that's what first attracted me to it.
Good stuff. Yeah. And so what's your sort of background in rural medicine, and what's kind of attracted you to it, and what have you done before?
Yeah, sure. I mean, so my general practice training was very, very urban. My training practice was Stockbridge in Edinburgh, so absolutely central Edinburgh, yeah. and my rotation was actually the central Edinburgh rotation. So all my hospital rotations were city hospitals, but I've previously lived and studied in the west of Ireland. My family, although we don't live in a rural area now, my grandparents and so on lived in very rural areas. So I've always been attracted to rural areas. I was a keen hill goer, enjoy the sea, lots of things. So I always had this yearning to do a little bit more sort of rural work. And there's an international group called WONCA, which is an unfortunate name, but it's basically the World Family Medicine Organization, and within WONCA they have a rural subgroup or committee, and they offer an exchange program every year for doctors in training called the Vasco da Gama Initiative. So in my final year of training, I applied for this sort of international exchange program. And I went and worked in a rural practice in the west of Ireland as part of my GP training in Edinburgh, which was a fantastic thing to do. And I had a brilliant time there. And the practice I worked in was quite rural, and I got to see how the GPs were sort of part of the community and how they needed to be orientated to the needs of the community in order to be a good doctor. And I found this extra tier of I guess complexity, but also a great opportunity to really provide holistic care. I found that really, and then other bits and pieces like working in nursing homes, community hospitals. It was a whole other portfolio of work that interested me. So as soon as I finished GP training, I applied for the Scottish NES funded Rural Fellowship Programme. And that was me really getting involved properly with rural medicine in Scotland. So would you like me to talk about the fellowship?
Yeah. So where did you go with the fellowship?
So the fellowship is, as I say, it's a NES funded initiative to try and give GPs in their early careers an opportunity to work in rural Scotland. There's when I applied for it, there was actually two streams. The traditional rural fellowship, which was a 12-month experience working in a rural practice in Scotland, and then there's a thing called the acute rural fellowship, which attracted me, and that was an opportunity to develop the enhanced skill set that you might need to work in a rural area that also looks after a community hospital or an A&E unit or whatever, and so I was delighted to go and work in Skye, in the Isle of Skye for a year as an acute rural fellow, which was a brilliant year. And it allowed you an opportunity to develop the skill set in order to work in this very bespoke area. It's interesting, at the time there wasn't really a clear pathway for rural doctors in Scotland, so it tended to attract folk who might have had previous clinical experience in anaesthetics or emergency medicine or whatever. And now the General Medical Council are looking at that. They're starting to introduce a credentialising pathway for rural medicine in Scotland. But when I was a rural fellow, the year involved me developing basic competencies in anaesthetics. So I got to do 3 months of anaesthetics, which you just wouldn't have an opportunity to fit that into your career otherwise. I got to do all of the various acute course tickets or qualifications. So your advanced trauma life support and advanced obstetric emergencies course and things like this. And that was brilliant. You got to meet a lot of the pre-hospital community in Scotland. We got to engage with basics quite a bit. And I did some advanced airway courses and things like this. So I started to feel more confident about working in an isolated rural and remote setting. And towards the end of the fellowship, actually, a substantive post came up in Skye as what's called a Rural Practitioner at the time. Now I think they're called Rural Emergency Physicians now. So I applied for that post and was delighted to be appointed, and I continued working there in a less than full-time capacity. I think I was 60% for just under a year, for 10 months. And that was, for me, it was the best job in medicine because, as I said, what I really like about clinical medicine is undifferentiated presentations, which for me is a core component of generalism. Yeah. I find that really exciting and stimulating, and also I don't think I have the aptitude to be a specialist to really delve down into the detail. I like having a sort of a breadth of experience, and you really are embracing a lifelong learning if you engage with generalism, I think, as you do really across the piece, but particularly I think in that area. I mean, if you think about the environment in Skye, I worked in Broadford in a place called McKinnon Memorial Hospital, which is a place, so I hope you get to spend some time there in your lick. And essentially it's about 20 inpatient beds. It's got a 24-hour non-bypass A&E that sees about 9,000 patients a year. Obviously there's a big swell in the summer with tourism, so it's difficult for the guys up there to resource how the year's going to work. It has a small maternity unit, a midwife-led maternity unit. So when I was there, about 25 deliveries a year, give or take, and the rural practitioner would support with any neonatal emergencies that we were chatting about earlier. And there's also, every week then I got to do a lumps and bumps clinic, so got to enhance my minor surgical skills. And we had a fracture clinic every Monday. So you could find yourself in a scenario where you would be aware of a patient in the community, you would admit them, you would see them in A&E and maybe stabilise them and transfer them, or stabilise them and think, I can keep them here safely, or their wishes were to stay on the island rather than be transferred across to Raigmore or Glasgow. So you'd admit them through that journey, and then you'd also be responsible for discharging them and communicating with the local GP. And so just the opportunity for teamwork and really joined up care between a multidisciplinary team is fantastic. And for me, I think it captured what I imagine what my definition would be around true generalism. You got to, so there's very few jobs like that left in medicine. So and I felt I grew a lot clinically during that period. So so that was sort of the kernel of Skye. Yeah,
sounds great. How did you adapt to sort of being from in a very urban setting in Edinburgh to then when you're moving out to Skye? Like, how does the lifestyle thing change? When you're living in that remote setting, how did you find that sort of transition?
Yeah, that's a good question. I mean, I think just naturally, I'm quite happy in rural areas. I like getting out and about, and as I say, getting into the hills or going for a run, and myself and my wife would often we would naturally holiday in areas like this. So to get to spend all your time there actually was a straightforward lifestyle adaptation. What do you miss about the city? I guess sometimes you just really hanker after that a boutique coffee shop that you used to go to that you can't do. No, but seriously, like some of the challenges I think to rural living that you might not anticipate until you get there is little things like that, like access to goods and services and so on. Particularly in the winter. I found in the summer there's lots of stuff going on, but in the winter in these places there's not so much available to you, particularly if you're not from the area. So that's something to consider. If you're from the area, you tend to have a more established social network. In saying that, the team that I worked with in McKinnon and the wider community were really embracing to us when we arrived, made us feel very welcome. Our neighbour, where we were living, there was a real community spirit in the place, and a real recognition that a medical service is critical for these communities to survive and thrive, and so the communities actually really go out of their way to try and support you when you're there. And I made some friends on Skye that I'm still friends with, and wouldn't have changed anything about the experience.
Yeah, because I suppose that's a sort of different aspect of being a doctor on somewhere like an island or in a really rural community, because you're the doctor there, but you're almost a wee bit more as well. You're a kind of key part of their community, and I suppose that comes with a lot of responsibility, but quite a different way of maybe viewing yourself as a doctor as well. How did you find that?
Yeah, that's a good question, Andrew. Like it's something that dawned on me more and more during the time that I was there. So to give you a really trivial example, sometimes you might have road rage or something, and there's just no room for that. You are, like it or not, you're a professional within the community, and people are interested in your point of view around things, and you're holding on to a lot of quite sensitive information, and you have to take that responsibility seriously. So all of the stuff that we talk to the students about it around confidentiality and consent and probity, that becomes really important when you're living in a small community like Skye. As somebody once said to me on Skye, if you want to know what's going on in Skye, just go to the local co-op, because you hear all the conversations in the aisles. So that does bring with it a sort of an extra awareness of your professional identity as a doctor that you might not be aware of in a bigger urban setting where you can be quite anonymous, and that's nice too. Thankfully, I didn't have much experience with this, but when things go wrong as a doctor in a rural area, that can be really hard on the practitioner, because obviously you're invested in the community, and you might feel sort of personally engage with any tragedy that happens. And there was when I worked in Skye, there was a number of sort of things, road traffic accidents and things that were really unfortunate that we were involved with. So it was it is something that you don't fully appreciate when you're working in a more urban setting. I guess the other thing that is sort of the other side to that coin is you become very aware about what's going on in the island, or in the community, let's just say. So if you're on call for a weekend and there's a rock festival on in Skye, you're very aware that might bring more business your way, for want of a better description. Or if there's, if the weather is clear and there's more hill goers, you might see more hill-related trauma. Or the one that really used to upset me was, unfortunately, if there was, speeding on the roads and things like that. I used to get quite upset about that. People taking risks, overtaking on corners and stuff. That used to upset me, because in a way that I wasn't probably aware of before, because you knew that you might have to engage with that, and you were very aware of the impact of that in the community when accidents happen. So these are some of the things that you reflect on when you're working in a more rural or remote community. I think I'm explaining all the negative sides to it. There's a whole host of positive sides to it as well.
Yeah.
One of the things that attracts me to medicine, I'm interested, as I said, in undifferentiated presentations, but I'm also really interested in people and their context and their because I think when you understand that, you can really deliver holistic care to people that's quite bespoke, and actually it aligns really well with the whole concept of realistic medicine. And so when you're working in a community like that, I think the term from the College of General Practice would be community orientation, but you become really orientated to the community and you understand them, you understand their pressures and the challenges that they face, and you understand what might drive them to want to stay on the island, even though medically it might not be the most ideal setting. So there's a real professional satisfaction that comes with that. Yeah. If I'm making sense on that, it's somewhat abstract, but when you really appreciate folk and where they're from, it's like the old thing around if a crofter arrives in to the hospital, it changes the
context of the consultation.
Totally, and the likelihood of significant pathology is much higher. And I think somebody did a study on this. Like, it was seen as an independent risk factor for something serious going on, because these people just don't leave their crofts unless they really have to. So that type of thing. Fishermen, I used to see quite a lot of fishing-related injuries that I wouldn't have ever anticipated. But for them to bring a boat in and a fisherman to come in and see somebody, it's usually pretty bad. So understanding that is great, and you understand where their motivations are and where they want to get to and so on. So there's pluses and minuses like everything.